Time for our staple of the show here on Sports Medicine Weekly. Welcome back, everybody. Steve Cashel, Dr. Brian Cole. It is our Ask the Doctor segment where we take questions from you, our listeners, and present them to Dr. Cole. Just go to our website, sportsmedicineweekly.com. On the home page, you will find our picture on the right side. Click on that link and type in your questions. And if you want us to call you, we can do that as well periodically from time to time, because right now, Dr. Cole, to kick off our Ask the Doctor segment, we've got a young woman named Sarah on, joining us all the way from Portland, Oregon. How are you, Sarah?
I'm well. How are you doing?
Good. Thanks for joining us here on Sports Medicine Weekly on this Saturday morning.
Thank you. My pleasure.
What's your question for Dr. Cole?
Well, I hike quite a bit, and I was noticing that my left hip is popping. It doesn't hurt, but whenever I'm going upstairs or up a hill, it pops or clicks with every single step, and I want to make sure I'm not damaging my hip, and if there's anything I need to do, if it's safe or what I can do.
We've talked about this before, the clicking, right? Because I have it in my ankles. You hear it in my knees. It's a typical common thing, isn't it, Dr. Cole?
Yeah, no, it's a great question because I've often joked that in my office that I would put a sign up on the counter that says, "Look, if you're here because you have a joint that's snapping or popping but doesn't swell, never had an injury and have no pain, please turn around and go home." But the problem is you're asking like the most basic question that everyone is concerned about, because it isn't. You wouldn't think it's natural for a joint to pop or snap or click. And the most important thing you said is that you don't have any pain. So I guess the first take home, and I think this is important for any problem, is you need to know that if you neglect it, will you cause a problem later on that otherwise could be made worse? And in addition to that, will activities make the problem worse now that you know your hip, in this example, is clicking or popping? And if you had the peace of mind to know that activities are not going to make a condition worse because you have this, and that ignoring it is not unsafe, that's a great sort of ground zero to start from, right? So I can tell you that that's the case. There's nothing dangerous about a non-painful clicking, snapping hip. Right. So now the question is, that doesn't mean it may not bother you. I mean, it could be a nuisance, and it might click every time you do a certain activity, and that's not necessarily that desirable by a lot of people. But I think at least giving you the reassurance to know, look, if you do nothing, we stop here. There's nothing to worry about in the future in terms of causing damage or creating a problem in the future that you wouldn't otherwise get. For example, if you treated it today. Okay, does that make sense?
Definitely, yes. I think my biggest concern was that I was damaging it by doing nothing.
Right. But I bet, is it a bother when you're hiking? Are you sort of in a situation where, like, I wish I didn't have this?
I would prefer not to have it.
Yeah. So the most common cause, the good news, as you say, it doesn't hurt, but the most common cause is an iliopsoas tendon, which is a tendon that runs across the front of the hip that sort of just snaps or catches over a bony prominence or a soft tissue area. And I would tell you that stretching, hip extension, stretching, some strengthening can often make a really big difference. It doesn't require an MRI, it doesn't require surgery, obviously, or anything like that, but there are stretching programs, and this is a situation where you might actually benefit by seeing a physical therapist. That can improve it. It can often go away as quickly as it came, right? And, if as long as it's staying in a situation where it's just not causing pain, it's perfectly reasonable to observe it. And as I said, if you want to improve it, I will tell you that flexibility, stretching, strengthening, all of those things can make a big difference. Not a great environment right now to sort of teach you all those things, but certainly seeing a physical therapist, you could probably get even a script. Actually, therapists, at least in Illinois now, they can actually do 10 visits without a doctor's prescription. I don't know what happens in Portland, Oregon, but they can do an injury screen and evaluate you and probably give you a series of exercises just to get started. If you need something more, not unreasonable to see a physician who can get you a prescription for more therapy. So
excellent.
Hopefully that's helpful.
Reassurance.
Yeah.
Yes.
Sarah, thanks so much for joining us here on Sports Medicine Weekly.
Thank you so much for having me. All right. I appreciate it.
Take care. Sarah from Portland, Oregon. Dr. Cole, I've got the next question right here. This was written in from Kevin asking you this. My hips have been clicking when I raise my legs laterally. I'm a hockey player, so I know that bad hips can be a result from the motion of skating, but again, almost like Sarah's question, is the clicking bad? If so, what can I do to get rid of it?
Well, the interesting thing about hockey players is the incidence of labral tears, which are tears on MRI, for example, that show the cartilage in the hip, is very, very high. In fact, we even see it in the NBA. But the incidence of those causing problems is very low. So the biggest challenge with a hockey player who comes into an office is, okay, well, let's just get an MRI. If someone doesn't listen to the patient, say, look, it doesn't hurt, it's not causing a disability, then you get an MRI, and then things can spiral if you're not thoughtful. So be prepared, especially as a hockey player, to have a significant abnormality on a hip MRI. Does that mean you need to do anything? No. Does that mean you need to change what you're doing skating-wise or other? No. Most of the times, the things on the MRI are not even related to the popping that you're experiencing.
All right, next question. Julie from Midlothian asks you this, Dr. Cole. What happens with a pinched nerve? I want to find that out myself.
So, that's a very generic sort of diagnosis or wastebasket category of, nerve symptoms. So people say pinched nerve and impinged nerve, things like that. Classically, I think the most common location or way that a nerve gets pinched is there could be a disc, for example, in the lower back of the neck that is bulging or herniated. There'll be a piece or a disc fragment that presses on a nerve, and that causes symptoms. And it can be pretty painful. It can be burning pain, numbness, tingling, get worse with certain positions. It can be very, very uncomfortable. So that's the classic definition of a pinched nerve. Now, there's others more subtleties to that in what we call somatic nerves in the upper back and so forth that can just be like sensory and cause achiness and pain and muscle spasm. That's maybe different than the sort of sciatica thing that people get where the nerve is infringed upon by something structural and getting pain down the butt region, back of the leg, all the way down to the foot. But the basic concept of a pinched nerve is that there's something structural that's pressing on the nerve, causing referred symptoms in the same sort of distribution or anatomy that nerve is meant to cover. So that's that. That's a pinched nerve.
Okay. Next question I've got here from Jake. He is calling us from Geneva. Actually, he wrote in this question. Are there any exercises you can suggest for shoulder arthritis? And boy, you know what? This one hits home for me too because I'm wondering. I mean, from the neck, base of the neck down there, down, and I continue to lift weights. It doesn't hurt really when I lift. I know my limitations, but you wake up in the morning and you just feel that. Is that arthritis? Why don't you explain to us first, Dr. Cole, what shoulder arthritis is?
So shoulder arthritis is, like any arthritic condition, is loss of cartilage. And what's interesting about the shoulder is that, if you just want to think about the incidence of it, we do about 400,000 knee replacements, maybe 500,000 hip replacements. There's only about roughly 100,000 shoulder replacements. So the incidence of people who present to the office with very advanced shoulder arthritis requiring a replacement is far less common than, say, a hip or a knee, okay? That being said, the condition is the same. It's just that for whatever reason, people tend to tolerate shoulder arthritis in other joints, maybe because it's less load-bearing. That's one of the explanations. But what happens is that they present with this achiness, this pain, maybe mechanical, painful condition, night discomfort, super common, and what's often always associated with is progressive loss of motion over the years. And it's that loss of motion and pain at the ends of motion that brings a person to the doctor's office. So things that can be done are to maintain the motion you have and then to work on stretching of the ball and socket joint. And that can be done with training from a therapist. And a lot of it can be done on your own. But that's an area where I will often use injections, maybe even cortisone into the joint, and then give a patient physical therapy and do our best to keep them out of the operating room. Sometimes it does require surgery, but it's not always a replacement. Sometimes we can go in and just sort of loosen up the capsule that's tight, make a more forgiving environment so that they respond better to rehabilitation, and save them from an immediate shoulder replacement and maybe, hopefully, put it off way into the future or maybe never at all in some instances.
So there's torn rotator cuffs, there's shoulder arthritis. You said loss of cartilage. How
does
one lose cartilage?
Yeah, loss of cartilage and arthritis are the same thing, and it's most commonly degenerative in nature. In other words, we're genetically programmed.
Does it dissolve?
It breaks down.
Okay.
It doesn't necessarily dissolve, but cartilage is a beautifully complex structure that looks perfect under the microscope. And what happens when it breaks down is it just starts to turn into crab meat. The surface breaks down. It just progressively erodes. Wow. It can peel off the bone. It can fragment. There can be fissures. And the joint finds it as a very noxious or irritating stimulant that makes fluid production in the joint, achiness, gives you all those symptoms that are just really, sometimes for some people, just unbearable.
Dr. Cole, next question for our Ask the Doctor segment comes from Tom in Colorado. Love these people from all over the country. It's about a hamstring injury while water skiing. I suffered a hamstring injury, what I think is a hamstring injury, Dr. Cole. Sharp pain in my middle of my back leg and hurts a lot. What do we do?
So water skiing is a common cause of hamstring tears. And the most common hamstring tear comes off the butt. You're right by that sitting bone, if you will. It's called the ischium. And when that happens, in some people, it has to be fixed. So it's a very painful injury at first. It happens when you try to get up with your legs too straight. Your knees are not bent. You try to get up, and you're bent over, and you're just muscling it up, and it pulls the hamstring right off the bone.
Goodness gracious.
I've seen it a lot. And fortunately, we have guys. I don't fix them anymore. I have Shane Noe and Chuck Bush-Joseph. They do a number of these in our practice. And gratifying surgery because you can fix it and make someone normal. The other common source of a hamstring tear is just mid-substance in the middle of it. And those don't require surgery. So if the person has pain in the middle of the back of the leg and has bruising and sort of a lump there, that's one that will get better with relative rest, time. Physical therapy can help immensely with stretching and so forth. And that's a whole different entity. It doesn't require surgery. The surgery one's a pain. I mean, it's a long recovery. It's a 4 to 6 month recovery, and it's a challenge because the post-op course is difficult. The one that Tom, I think, is describing is more in the middle, in the back of his leg, and that's a mid-belly muscle tendon injury, which is different. That gets better reasonably quick, but that's like a 6 to 8 week phenomenon that requires no surgery, just compression, rice, exercise, stretching, and so forth.
The one you first mentioned sounds almost like a torn Achilles.
Similar in concept. Achilles is sort of a mid-tendon tear. It pulls right off the bone. So, yeah, not fun.
Gracious.
Not fun.
Wow.
But, good question, and sure many of our listeners, unfortunately, have experienced something in this family.
And we are out of time for this edition of Sports Medicine Weekly. Many thanks to our producer, Shane Reardon. Coordinating producer is Teresa Ann Seeger. Many thanks to David Cole for our business operations, running the website, and Samantha Smith from Midwest Orthopaedics at Rush. Coming up next here on The Score, we've got Inside the Clubhouse with Bruce Levine and David Schuster. We'll talk with you again next week. For Dr. Brian Cole, I'm Steve Cashel. Thanks for listening to Sports Medicine Weekly, only on
670 The Score.